My name is Dr. Sinjini Biswas. I'm an interventional cardiologist at the Bristol Heart Institute in the UK, and I'm very grateful for the opportunity to present this case today, which I've titled Getting Out of Jail, but Not in One Piece. This is a case of a 67-year-old gentleman who presented to our institution with an anterior STEMI. He had minimal cardiac risk factors, and in STEMIs, I usually take a shot of the non-culprit vessel first, which is shown here, and that shows a large dominant RCA that has minimal disease. On taking shots of his left system with an EBU-35 guide, it was clear that he had a severe ostial circumflex lesion, but it was actually his LAD that was the culprit vessel, with thrombus evident at the level of the diagonal branch. And after wiring with a cyan blue and pre-dilatation, I deployed a 3.0 by 24 Synergy stent in the proximal to mid-LAD, with the results shown here. After post-dilating the stent with 3.5 and 4.0 NC balloons, I then undertook intravascular imaging with IVUS to make an assessment of the acute stent result and assessing the LAD ostium for future procedural planning. This actually shows relative freedom of disease of the ostium of the LAD and a reasonable acute stent result in the mid-LAD. Given that treating the ostial circumflex would necessitate stenting back to the left main, I decided to stop at this stage and to discuss him at the MDT, where it was felt that with isolated ostial circumflex disease, it was reasonable to treat this lesion percutaneously rather than with a surgical revascularization strategy. So I arranged for him to come back 2 days later with a plan to undertake a layered provisional strategy to treat his left main into the circumflex and then to consider reopening the struts into the LAD at the end. So I took a 7 French EBU-35 guide, wired the circumflex with a cyan blue and the LAD with a turn track wire, which are the two main workhorse wires which we have in our lab here. After pre-dilatation to create some space, I undertook an IVUS assessment of the left main to the circumflex. You can see here that the left main is quite large at 4.5 to 5 millimeters, and the proximal circumflex itself is quite big at 4 millimeters. I haven't shown you the IVUS of the lesion itself, but it showed soft plaque with no significant calcification. So I took a 4.0 by 16 megatron stent for purposes of its radial strength from the left main to the circumflex. IVUS shows the left main ostium is healthy, and so we purposefully chose not to extend the stent back to the ostium. And so this is the immediate post-stent result, where the LAD ostium appears pinched, and so the plan was to rewire into the LAD, open the struts, and do a kissing balloon inflation. But before doing that, to overcome the differential in size between the circumflex and the left main, I did a pot on the left main with a 4.5 NC balloon, and on this clear stent image, you can see the interventional wire the pot balloon is on, and the wire that is jailed into the LAD lying under the stent. So at this point, I took a fresh cyan blue wire to rewire into the LAD through the megatron stent, and then wanted to take the jailed wire out. However, on pulling the jailed wire, I couldn't feel any resistance, I wasn't pulling hard, and the wire was coming back out of the TUI, but I couldn't see the turn track tip move back on the screen. So my immediate worry was that I'd damaged the wire and that it was perhaps unraveling, and so I called for help with a colleague, who then scrubbed in. Took a 1.0 sapphire balloon down on the wire with a view to burying it under the stent and pulling the whole thing out as a single unit. But what became quickly apparent was that as Tom pulled more, this came out. And essentially the wire outside the body was detached to the segment of wire in the coronary. So, what do we have now? We know we have a stent in the circumflex back to the left main and an interventional wire. We know we have a jailed wire behind the stent into the LAD that's broken somewhere, but what we don't know is where it is fractured. Has it done it somewhere back in the guide, like option A? Do we have a wire that's fractured at the point of the edge of the stent? Do we have a wire where the back end is hanging somewhere in the aorta? Or do we have a wire embedded deep somewhere behind the stent that just extends out to the distal vessel? And the next question then is, how has the wire fractured? Is it a sharp fractured end? Is a single filament that's coming out, or do we have multiple filaments coming out of the wire? And so it is this point where imaging was very useful, and you can see some incredible images of these multiple filaments just sitting in the lumen of the vessel on this IVUS. And moreover, when we came to withdraw the IVUS catheter, it becomes evident that the IVUS catheter has managed to extract quite a lot of this material, so it's all caught up in the V angle between the IVUS monorail and the guide wire. We pulled all of these filamentous material out. And so we did that a few times, and every time the repeat IVUS images showed fewer and fewer filaments, and every time we got out all this hair-like material caught between the IVUS and the wire. And so we thought that's a win. And then we did the IVUS again, and I've truncated the run, but hopefully you can see that there are still some filaments in the left main, and filaments going back into the guide, which I've just highlighted here. So now we have confirmation that the wire has definitely fractured somewhere in the guide. What are our retrieval options now? Well, firstly, we could snare it out. However, it would be likely to be challenging to cross with a snare through the side of the left main to circumflex stent struts into the LAD. And we need to consider that this is a recently implanted mid-LAD stent, which could be damaged or dislodged with the snare. Furthermore, the jailed wire tip is located very distally, and even if we did manage to get hold of it with a snare, it's unknown how the wire would behave when retracted given it's behind the left main stent. The other option would be to snare proximally. This also carries the risk of dislodgement of the fresh left main stent, and the degree of wire integrity between the visible tip and the guide is actually uncertain. But we'd decided that we'd have a last-ditch attempt at taking a micro snare to mop up some of the stuff at the front end, the left main, but actually it didn't bring much material out. The other option that we thought was we could trap it out. So we could trap everything in the guide and take everything out, but then we'd lose all our wire and guide position. So before we do that and lose all our wire positions, we decided to optimize the distal left main bifurcation with kissing balloon inflations. We then used a trapping balloon in the guide to bring it all out, but that actually didn't bring much material. But what we didn't notice at this point in time is that the wire tip that was very distal has actually now come back much more proximally if you compare the two images on your screen. So now we have no guide, no interventional wires, a left main to circumflex stent and a mid-LAD stent, but a stuck wire tip. And our options were now just left to stent the proximal LAD and cover up whatever's left behind, or try and retrieve a bit more. But if so, how? We made the decision to go with option 2. Now that the fractured wire tip was clearly more mobile, we thought it would be worth making an attempt to remove it all via a snare. So, how can we snare safely? We went back in with a 7 French EBU35 guide, rewired with a cyan blue in the LAD, ensuring on IVUS that the wire is not abluminal at any stage, and then took a 6 French guidezilla over a balloon to go into it, and through the side of the left main to circumflex stent into the LAD so that the guide extension is now at the level of the wire tip. And we've simulated this on the right on a benchtop model as well, which you can hopefully appreciate the guide extension catheter moving forward. We then took the microcatheter that comes with the gooseneck snare down out of the guide extension catheter, as you can see on both the simulation and the angiogram. We then catch the tip of the wire through the micro snare, and as we pull, the forces are applied around the tip of the guide extension and not then potentially shearing it around the left main stent and damaging this fresh stent. And you can see here it all comes back in this absolutely wonderful moment after many hours of fighting with this wire tip, where the jailed wire involuting around the tip of the guide extension catheter. We hope that most of it is now gone, but IVUS shows 1 or 2 filaments hanging around, and so we complete an extended culotte to cover it from the proximal of the LAD back to the left main ostium. So stented the proximal LAD back to left main with a 40x28 synergy, did a pot in the left main with a 45 NC balloon, recrossed into the circumflex with a cyan blue, and opened the struts out in the circumflex with a 20 balloon, and then did kissing balloon inflations with a 40 NC in the LAD and a 35 in the circ. And so this was our final result in the LAD angiographically and also on IVUS, which we were really quite happy with and thought it was quite a reasonable result from where we started. So what are my learning points from this case? Firstly, guide wire fracture is a rare complication. There are several risk factors, including tortuosity, calcification, forceful pulling of a wire, and having jailed wires. It's important to be familiar with techniques to remove fractured guide wires, some of which I've illustrated in the case and also in the cartoons on the right. As was illustrated in this case, imaging is fundamental to understand what is happening and to tailor the technique that you use. And finally, in a complication, stay calm, think systematically through the options, and use your colleagues to help you out, especially earlier in your career. Thank you.